My grandfather died at age 42 and left my grandmother with 4 sons and a daughter. They raised cotton and peanuts. And then the Dust Bowl hit, and they were really hurting. As a result, they moved to California, and they lived Steinbeck's Grapes of Wrath. And when they arrived there, they had no shoes. That just shows how poor they were. But about that same time, middle of the 30s, the winds of war were on, and the U.S. developed industries apart from farming. But my father didn't really work in that group. He went on further north to Ventura, where an oil field was being developed and supported the Pacific Fleet. I was born in July 1937. Still in the Depression, and that had a strong influence on me as well, in that we were pretty impoverished. My mother, she was a farm girl, but education was a major theme in her life and her brothers, and they all became teachers. My father was transferred from Ventura to Taft, California. Taft, California was a dusty, barren, stark place with a few hills and multiple oil derricks. He was working for Richfield Oil Company as a roustabout. As I grew up, my mother's emphasis on education sort of started my life of education. Started out in the Taft Library, and I read many, many, many books when I was a child. Going to Taft was a big luxury, it turns out, because Standard Oil of California was the dominant company in that town. And Taft schools had the biggest endowment in California. And the prominent people in town were the teachers. And we respected the teachers in education. I thought I would be probably an oil worker, very much like my father, because that's what you do, you follow in the footsteps of your father. But my peers and the teachers elevated my ambition, and I decided I would go to college. When I was a sophomore, my favorite teacher was Alice Atwood, who was a biology teacher. And I told her I wanted to be an entomologist, do something in life sciences, and entomology was it. She said, maybe you would like to be a doctor. As I got near senior year, I was talking to my English teacher, who was kind of a gruff, and he said, what are you doing next year? And I said, well, I had thought about and think I'll go to UCLA. He said, no, you really don't want to go to UCLA. You want to go to the University of California at Berkeley. And said, I think Berkeley is a better school. And so I tore up my application to UCLA. I enjoyed my pre-med studies, and I did play baseball for a little over a year. But I found that I really didn't have the arm to throw in a double play. I wasn't going to make it really big time, if you would. And so I gave it up. I decided to play rugby instead, which is sort of a form of football, but a precursor of football. So I did enjoy that. And at that time, they were getting ready for Vietnam, I think, and they were trying to push people through to medical school in 3 years, if you could do it. And so I said, well, why not? I'll just apply. I applied, and by golly, I was accepted. I went to the first class, actually, that was as freshman at the University of California, San Francisco. I didn't particularly care for the first couple of years, which are non-clinical, in which you learned all the basics of anatomy, physiology, microbiology, etc. But I did really enjoy the subsequent clinical years. The thing that I did really well in was psychiatry, but the thing I liked best was surgery. While in San Francisco, I met my wife, Sylvia, and she was a nurse at the nursing school at the University of California. We got married after my second year, and by my fourth year, my daughter was born. Money was tight. And so I saw that I might join the Navy because the Navy was willing to pay me a stipend, my tuition, books, virtually a free ride. And so beginning my third year in medical school, I became a naval ensign. That afforded me the ability to go through medical school without having to worry. I graduated and went on to the University of Utah, where I spent a year as a rotating intern. Got through it, and at the end of that year, the Navy had my future in its hands. So I called the Bureau of Medicine at the end because I hadn't heard anything from them. And they said, "You're due in Japan day after tomorrow." I went there first, and my wife followed me in a month. And at that time, I was a general medical officer. Saw lots of patients, did lots of general practice. During that time, the Vietnam War was beginning to accelerate a bit, and the Vietnam administrators were losing contact with rural Vietnam. They had decided that they were going to create a psychological warfare unit to go into the field and meet with the rural people and try to convince them that the people in Saigon who were in charge of the South Korea were worth supporting. I got assigned to go to Vietnam at that time. They gave us a World War II ship, an LSM. It was a landing ship. And on it, he mounted 3 semi-truck trailers, one of which is surgery, one was a dental office, and one was a clinic. But as psychological warfare people, we also had a band, a priest, a monk, dancing girls, a video show team. And so when we arrived at a place, which is usually at the mouth of a river, it was like a carnival coming to town. I went out on another naval ship. We contacted enemy at night. We were shot at. You could see the flashes of gunfire, and we shot back at the enemy at that time in the night. So that was an experience that is vivid in my mind. The other thing vivid in my mind is the Beatles. I associate the Beatles, and You Got a Ticket to Ride with the Mekong Delta, where you could see the artillery firing. Armed Forces Radio would play songs. Clearly, as history shows, we were not successful in attracting the rural Vietnam to the administration, governmental administration in Saigon. I have often said that war did nothing but train surgeons. Nothing else came of it. Upon arrival back in Japan, I had applied for general surgery residency, and I got back to find that I had been accepted and ended up back in San Diego at the Naval Hospital Balboa. That hospital was the receiving site for all the Vietnam wounded. It was the Veterans Hospital. It was the Children's Hospital. As a result, we were extremely busy. At the end of my general surgery residency in San Diego, I had been asked by the chief of surgery at Bremerton Hospital to come there. And they said, yes, there was a space there. So I transferred to Bremerton Naval Hospital. It was a general surgery practice that exposed me to all kinds of surgery. There was a proctologist at the Naval Hospital in San Diego. His name was Paul Seabrechts. He introduced me to this, something that I thought, this is where I think we can make some inroads. And I started looking at colon and rectal surgery. Fortunately, at that time, for me, the Surgeon General was Robert Davis. Robert Davis had been the chief of medicine at Oak Knoll Naval Hospital when I was a medical student. So I wrote him a letter and said, I know there have been no colon rectal surgeons in the Navy. However, I'd like to apply for one. I was at the ACS meeting, American College of Surgeons meeting in Chicago. And at the request of, I think, the Surgeon General, the Deputy Surgeon General interviewed me and intimated to me that I would be approved for the colon and rectal surgery residency. While in Chicago, Stan Goldberg ran me down and found me and said, "Why don't you come by our place in Minneapolis?" So I went to Minneapolis, and I was really impressed. And I got accepted, and I think he was at that time really anxious to have residents come there at all. Subsequently, it became very hard to get a position at that residency. I came to know him as a great teacher, taught me the basic principles of colon and rectal surgery, and we became very good friends. And my best friend in colorectal surgery was the next resident in line of me, Phil Gordon, a superb technician and thinker in colorectal surgery. We took delivery while I was there on one of the first colonoscopes in Minneapolis. I got a call from Santat Abatvangs one day who said, "I have a polyp, first polyp." Raced back down to the University Hospital, and there was this rather dinky little polyp in the colon there. This was sort of the beginning of modern colon and rectal surgery, and we created this little snare, and we put it through the scope, cut the polyp off, and we were very pleased to find that it was not a cancer and that it was something we could do without difficulty. The colonoscope then I recognized was going to be something special, and I consider one of the real breakpoints in colon and rectal surgery. While with Dr. Goldberg, he told me a couple of things that have really changed my life. He said, one thing, we don't have enough academic surgeons. We need people not necessarily in the clinics, but in the universities around the country. And number two, he said, we don't have enough residencies. We need more colon and rectal surgeons in the United States. And I took this to heart and kept it. He allowed me to go and visit with and work with other surgeons at the other residencies. I went to the Oxford Clinic, the Leahy Clinic, the Mayo Clinic, and the Ferguson Clinic, the Cleveland Clinic. I scrubbed with Rupert Turnbull, did some surgery with him, and as I finished my residency, they gave me the last couple of weeks to go to St. Mark's Hospital, where I stayed for a couple of months in London. It was an amazingly wonderful trip. After coming back to the U.S., the Navy was kind enough to send me to the National Naval Medical Center in Bethesda, Maryland. I was the first colorectal surgeon in the Navy with the title of colon and rectal surgery. While I was at the Naval Hospital, the Uniformed Services University of the Health Sciences was begun on the grounds of the Naval Hospital, and I was started as an assistant professor right off the start. And so that was my introduction to academia with title. When I went there, Bill Foudy, who was chief of surgery, had ordered a colonoscope. So when I arrived there was a colonoscope waiting for me. We had no endoscopy suite. So we converted a closet in my office to the endoscopy suite. The only monitoring we had was a blood pressure cuff, and that was the accepted practice in our endoscopy suite. In 1973, at the time of our boards, we took our written at one time and our oral exam at another time, having passed the written. And so the written was in Detroit, passed it, went to New Orleans a few weeks later. One of my attendees, if you would, was Ernestine Hambrick, who was the first woman to take the boards and pass the boards in colorectal surgery. She got the best grade, and I was told subsequently that I got the second best. In 1973, I took my boards, and this permitted me to become a member of ASCRS. And interestingly, that was the same year at the ASCRS meeting, a vote was taken to change the name of the American Society of Proctology to the American Society of Colorectal Surgeons. ASCRS was a platform for being able to express ideas and learn from others while serving on committees, and we taught courses on endoscopy and stapling and laboratory study and colonoscopy, and finally laparoscopy. I was the first colorectal surgeon in the Navy with the title colorectal surgery. Colorectal surgery was pretty primitive and needed to be improved. It just came that we should study the anal rectum, and therefore began to start a laboratory for studying the anus, rectum, and colon. Dr. Castell in gastroenterology was also at that institution at that time. And he was studying the lower esophageal sphincter. And I thought, sphincter? We can apply some of the same techniques that they were using in the lower esophageal sphincter to the anal sphincter. And so, using manometry equipment, devising our own tubes made from nasogastric tubes, we started doing studies of both the ability to contract and the resting pressures of the anal sphincter. We also began to do transit times of the colon, and we did that by taking capsules, cutting nasogastric tubes which had radiopaque markers on them, and stuffing them into the capsules and having them swallow and timing the time that they went through the GI tract and colon to study constipation. We also started to study defecating proctography. Defecating proctography was a chance to look at the pelvic floor. And so we made a special concoction that we inject, which we would insert into the rectum. This mixture was mashed potatoes, dried mashed potatoes, and barium. And we would mix it up and insert it into the rectum and then take x-rays of the pelvic floor as defecation occurred. So it was pretty primitive, but it was the start of a lab. Shortly thereafter, staplers were introduced. Staplers had already been introduced, but the first circular staplers were introduced. And so we started doing the first circular anastomoses in Washington, D.C. at the Naval Hospital. Chief of surgery while I was at the Naval Hospital was Bill Foudy. One day he called me in and said, "How would you like to work a day a month doing screening sigmoidoscopies for the Congress, the Supreme Court, the cabinet members?" I said, "Sure." I thought that would be really worthwhile. There was a medical department at the Capitol, and one day a month I had an office where we did sigmoidoscopy for this group of politicians. I did see a lot of people who were well known. I did see President Ford at one time, which did the sigmoidoscopy for him at his annual physical. Virtually all the Supreme Court justices operated on some. Potter Stewart, Lewis Powell, Thurgood Marshall. Justice Brennan was my favorite. Justice Brennan, in fact, invited me to come with my family down to have lunch at the Supreme Court. Went to the Supreme Court, had a nice lunch, and then listened to the arguments that were taking place in the Supreme Court that day. While at the National Naval Medical Center, I got a call from Admiral Lukash. Admiral Lukash was the White House physician, and he said to me, "President Carter has hemorrhoids, and I'd like you to take a look at them for me." So I jumped in my little Volvo with my technician, drove down to the White House, drove in, and they said, "Oh yeah, we're expecting you." They just let me drive in, and I parked under the portico at the White House. The only house call I ever made. They have a medical unit at the White House, and there was President Carter. And I talked to him and found out that he had had trouble with hemorrhoids in the past, examined him and found that he had prolapsing hemorrhoids that were painful to him. While we were standing there, getting ready to do this, the phone rang. Admiral Lukash answered it, and he said, "Yes, yes." And he said, "It's for you, President Carter." And he handed the phone to the president. And the president listened and listened. He turned to me and handed me the phone and said, "It's for you." And so I said, "Hello?" And the other person says, "Hello." She says, "This is Miss Lillian, the president's mother." She said, "I would like to let you know that his father also had hemorrhoids, and I treated him with an ice pack." We went on to rubber band those hemorrhoids for the president, and lo and behold, at 3 o'clock that morning, got a call and said he's in exquisite pain and he had thrombosed adjacent hemorrhoids to the place I had rubber banded them. Fortunately, I had already told him this could happen as a complication. That was the only day of work he missed during his presidency. Retirement from the Navy in 1982, I actually came to Seattle for the better part of 1 year in private practice. And I got a call from the chief of surgery at George Washington to ask me to come back to Washington and start a section of colon rectal surgery at the George Washington University. And I did. While at George Washington, it was probably the most active time academically that I had in my entire career. During that time, I had set up a laboratory for study of the anus and rectum, and education continued to be a major theme in my academic career. And so I had multiple, probably 100 different courses offered to postgraduates in colorectal surgery. These courses included flexible sigmoidoscopy to start with. There were lots of primary care doctors and gastroenterologists who took these courses. But flexible endoscopy, use of lasers in surgery, the use of ultrasound in looking at the anus and rectum, finally, transanal endoscopic microsurgery to take out rectal lesions, and subsequently laparoscopy. Early July 1985, I got a call from Dale Aller, who is now chief of surgery at the National Naval Medical Center. Dale had been a resident of mine when I first arrived at the National Naval Medical Center. He said to me on the telephone, "Could you come to my office?" I said, "Why?" And he said, "I can't tell you. It's not a secure telephone line. Just come." I left and I went down to the National Naval Medical Center. Upon arrival, he closed the door and said, "President Reagan had a polyp discovered today in his right colon. It's sessile, could not be removed colonoscopically, and they have decided to go ahead and have surgery in the morning. Can you be part of our team?" I said, "Of course, yes." So the next morning we convened at the operating room in the National Naval Medical Center, and lo and behold, surprising to me, there were Secret Service people in greens all around. Prior to going in it, had met the president. We talked about the surgery, had met Nancy Reagan and told her about it a bit, and went ahead with the surgery. It went extremely well. All his organs were pristine, like a young man. He did have a lesion in his right colon, which came out with the right colectomy. It was not stapled, it was hand sewn. At the end of the operation, everybody left the room except me, and I was left there, and I said to myself, "Check that specimen." So I grabbed the specimen and felt it, and I could feel a hard lump in the specimen. I said to myself, he's got a cancer in there. About the same time, somebody said, you're going to be late for the press conference. Well, I hadn't been nervous for the operation at all, but now I'm nervous. I hurry out, and there in the auditorium is all the people, the usual press for the White House. Helen Thomas was there in her red dress. Interestingly enough, there were very few questions. And that was it. And so I was very relieved that it was over, frankly. In follow-up to the recommendation of Stanley Goldberg, I felt that I should continue in academia and not become a private practice colorectal surgeon, and went back to George Washington University. I had initially at George Washington tried to get a residency in colorectal surgery. And in fact, I had approached the Surgeon Generals of all the military, but I personally did not have the volume of cases to sustain a residency at that time. The other element, funding for a residency, was not available at that time. Therefore, the politics wasn't exactly right. The patient load was not quite right. The funding is not right, so it fell through. We could not start a residency. John Kirkpatrick, who is chairman of the Department of Surgery at the Washington Hospital Center, approached me and said, would you come to the Washington Hospital Center? I said yes, if we would keep in mind that possible residency would be in the future. So I went to the hospital center, and after 3 years, decided that we would approach a residency again, and this time, the politics are right. The chief of surgery says, I will accept colorectal surgery. So in 1989, we were able to start colorectal residency. During the time I was at George Washington, I was fairly prolific in writing. Wrote most of the 80-some articles that I was involved with, and I wrote probably 80 chapters for textbooks. Probably the most important textbook I was involved in was authored by Philip Gordon, my former resident fellow, and Santat Navatvangs, who had been one of my mentors when I started out. This textbook, I thought at that time, was the best textbook there was available in colorectal surgery, and they asked me to write about 6 chapters in that book. Colorectal surgeons were endoscopists. Endoscopy was saved for surgery by colorectal surgery. What happened in 1989? Something very special. People were dabbling in laparoscopic cholecystectomy in the country. I had not heard about it. In Louisville, in 1989, Chuck Haney, one of the best residents in general surgery that I ever had, and I were walking around the exhibit hall at Sages, a meeting in Louisville. Jacques Perrosseau from Bordeaux, France, had asked to be an exhibitor because he had brought a video with him. He had this video of a laparoscopic cholecystectomy. I was at that time the incoming president of Sages and decided to take laparoscopic cholecystectomy as our baby. And so we wrote the requirements for being able to perform laparoscopy, the requirements for hospital credentialing, basically took over laparoscopy for Sages. That was a big accomplishment. I consider the beginnings of laparoscopy in this country. In 1992, Rick Billingham in ASCRS and me were given the task of going to U.S. Surgical and Ethicon to get their help in establishing classes to teach laparoscopic colectomy to colorectal surgeons. Although there was a lull at that time because it was not sure whether cancer could be cured as well by laparoscopic surgery as by open surgery. Therefore, there was a lull while a double-blind study was performed to see if that happened. And indeed, it turned out to be about equal, Therefore, laparoscopic colectomy became the standard of care for treatment of colon cancer. ASCRS is the primary postgraduate training and educational facility for colorectal surgeons. My beginnings of the politics and the administration of colorectal surgery began in 1980. I had just returned from being at sea with the Marines and still in the Navy. They had asked me to become a council member, and I served for 1 year. I served on many of the committees. The theme of education continued. One of the educational tools that colorectal surgeons has, diseases of the colon rectum, and I was happy to be one of the associate editors for 10 years, mainly during the 1980s. In 1993, I was president of the board of colorectal surgery. In approximately 1995, Philip Gordon, who was president of the American Society of Colorectal Surgeons, asked me to lead a committee of 3 to select someone to be the next editor of Diseases of the Colon and Rectum to replace Bob Beert. We interviewed a number of people and came up with Victor Fazio as the prime candidate, and he succeeded Bob Beert as editor of the Diseases of the Colon and Rectum. In 1999, I received a phone call from the then chief of surgery, John DeNoble. We have Ruth Bader Ginsburg here. Her history was that she had been in Egypt, had a bout of diverticulitis, perforated, treated with antibiotics, was sent to Frankfurt, where she was stabilized again, and then transferred to the United States. And she did not like the radiologist and would like to transfer hospitals. Would you take her? She came over, we met, we got along. I said early on, we've got to do a colonoscopy. That time, found the perforation, but adjacent to the perforation was a cancer. It looked like a cancer. And did surgery for her. Tumor was confined to the bowel and cured her, as a matter of fact. As part of her follow-up, she had colonoscopy by me, and she had MRIs and all the blood tests that usually go with follow-up. At one of these follow-ups, an MRI did show that she had a lesion in her pancreas, went on to have another cancer, and in addition to the pancreatic cancer, she had a lung cancer, and these were the cause of her demise ultimately. I was asked by Philip Gordon and Victor Fazio in 1998 if I would be a candidate to be president of the society. I was selected as the president-elect in 1997, so that in 1998, I was brought in as president of the society. It was with a great honor that I was president of the society in 1999. Why? That was the year of our 100th anniversary for ASCRS. In addition, that was the tripartite meeting, and people from around the world gathered with us in Washington, D.C. for that event. There was a 100-year book created by Byron Gathright, which went through the history of our society. For that meeting, I arranged for the Marine Corps Drum and Bugle Corps to be the honor guard and play the national anthem. We had Hillary Clinton give a video congratulations. Looking back upon my life, I see education as the cornerstone of my development. Modern colorectal surgery was what I lived. I think that learning never stops. Don't forget, some of you should strive to become academicians and should strive to promote residencies in colorectal surgery. Times are a-changin'. People are having new ideas, people are developing new technology, and you need to stay abreast of what's going on in the future.